Now we are going to see about anaplastic thyroid carcinoma. It is the least common type of thyroid malignancy and it is more common in 5th and 6th decade of life. In the elderly age group it is more common and it is also more common in females than in males. Like any other thyroid carcinoma, it is also more common in females. Papillary thyroid carcinoma, follicular thyroid carcinoma, this anaplastic thyroid carcinoma, everything it is more common in females. It is the most aggressive type of thyroid carcinoma, so it carries worst prognosis. Worst prognosis, patient will die within 6 months of diagnosing this anaplastic thyroid carcinoma. Most common mutation involved is P53 mutation and it is undifferentiated type of thyroid malignancy. What we saw earlier, papillary and follicular, they both are differentiated type of thyroid malignancy. This is a undifferentiated type of thyroid carcinoma. Patient will present with rapidly progressive thyroid swelling. That swelling will be the swelling in front of the neck, it will be rapidly progressive and the consistency will be hard in consistency, irregular and infiltrating. It will infiltrate the nearby structures, hard in consistency. So the differential diagnosis for this anaplastic because of this consistency is Riddle's thyroiditis. Riddle's thyroiditis will also be hard in consistency. Local invasion, because it is infiltrating the nearby structures, it will infiltrate the recurrent laryngeal nerve to cause hoarseness of voice. It will infiltrate the trachea in order to cause stridor. There will be also Berry sign. What is Berry sign? In the carotid pulsation, it will not be seen in its normal position, or else the carotid pulsation will be totally absent, because this tumor will go and engulf the carotid, or else it will push the carotid to posteriorly, so that there will be positive Beryllium, that there will be no pulsation at all, or else the pulsation will not be seen in the normal position. Risk factor: long-standing MNG multinodular goiter may transform into anaplastic thyroid carcinoma. Already we saw multinodular goiter may progress to follicular thyroid carcinoma. Most common type of progression, multinodular goiter most commonly progresses to follicular thyroid carcinoma. It can also progress to anaplastic thyroid carcinoma. Distant metastasis, it goes to the lungs. And FNAC is diagnostic. If FNAC is inconclusive, FNAC, sometimes we may not be able to differentiate between thyroid lymphoma and this anaplastic thyroid carcinoma. That time we are going to do true cut biopsy. Usually true cut biopsy is not done in thyroid malignancy. Why? In thyroid as a total, because they will go, because thyroid is a vascular structure, we don't know where the vessels are. When we do true cut biopsy, it may puncture the vessels and it may cause profuse bleeding. So usually true cut biopsy is not done. True cut biopsy is indicated in 3 places. Whenever this anaplastic thyroid carcinoma, it is inconclusive, or else in case of this lymphoma, or else in Riddle's thyroiditis, we are going to do true cut biopsy. Otherwise FNAC is diagnostic. Management, it is totally palliative. If it is a localized to the thyroid, we can go for aggressive surgery like the end surgery, total. We are going to remove the thyroid, central lymph nodes and all the nodes we are going to remove if it is a localized to the thyroid. Otherwise we are going for palliative. If this is not possible, we are going for external radiotherapy. Radioactive ablation, it is not done. It cannot be done because these cells, they don't uptake the iodine, so that is not possible. Otherwise we can go for tumor debulking. What we are going to do in this thyroid, it will be a large thyroid. So what we are going to do is we are going to cut the isthmus so that patient can breathe. So we are just doing a palliative surgery, or else if that is not possible, you are going for tracheostomy, something that is done to relieve the symptoms of that dyspnea, that symptoms it is relieved. So this is the management of anaplastic thyroid carcinoma. Next we are going to see about thyroid lymphoma. Lymphoma, it is also seen in the elderly age group. The lymphoma here is a non-Hodgkin B-cell lymphoma, like diffuse large B-cell lymphoma. These type of lymphoma are seen here. Patient usually present with a thyroid swelling. Other symptoms that are present are B symptoms, which are seen in this lymphoma, like weight loss, night sweats, fever. These are seen here. FNAC cannot characterize this lymphoma. So, as we saw earlier, true cut biopsy is done. If FNAC is done, we can see Hertel cells. As seen here, these type of cells can be seen in FNAC. Hertel cells can be seen in FNAC. Treatment is we can't do any surgery here, so we are going to go for chemotherapy followed by radiotherapy. Chemotherapy, what regimen is followed? Like any other lymphoma, we are going to follow R-CHOP regimen. R for rituximab, cyclophosphamide, hydroxydonorubicin, oncovin or vincristine and prednisolone. This is all about thyroid lymphoma. Next we are going to see about medullary carcinoma of thyroid. These medullary carcinoma of thyroids, they develop from the parafollicular C cells which are derived from the neural crest. These parafollicular C cells, they are seen outside this follicular cells. These are the parafollicular cells. The most important, most common mutation here is 634, codon 634. Usually it is more common sporadic than familial. This occurs in third and fourth decade, in some third and fourth decade, whereas familial, it occurs in a younger age group and it is usually more aggressive. This sporadic is not as aggressive as this familial type. Familial type, it occurs in MEN syndrome, MEN2 syndrome. MEN2 syndrome in both MEN2A and MEN2B, this medullary carcinoma of thyroid is going to occur, but MEN2B is more aggressive than MEN2A. Patient presents most commonly with thyroid swelling. They can also present with flushing and diarrhea. Why this flushing is coming? Because they release histamine, so flushing is seen. They release serotonin also, that causes diarrhea. They also metastasis to the lymph node, also to the distant structures. Distant metastasis is most commonly seen in the liver, whereas lymph node metastasis is seen in level 6 and level 7 lymph nodes. Diagnosis is by FNAC. FNAC shows stromal amyloid. Amyloid-rich stroma will be seen in FNAC. The tumor marker is calcitonin. This calcitonin is secreted by the parafollicular C cells. Because of the secrete calcitonin, this calcitonin is used as a tumor marker. Management is, before we are going to do any surgery, we are going to rule out pheochromocytoma, because this MEN2 syndrome is associated with this pheochromocytoma. These patients may present with palpitation, headache and also increased BP. Also postural hypotension can also be seen. These may cause complication during the surgery. So first, if you are diagnosing a medullary thyroid carcinoma, we are going to rule out pheochromocytoma. Also we are going to rule out the mutation, that same syndrome, the MEN syndrome in the family also. If medullary thyroid carcinoma is present in the thyroid, we are going to do total thyroidectomy with central lymph node dissection. In papillary thyroid carcinoma and follicular thyroid carcinoma, what we did? We did only total thyroidectomy. Here, in case of medullary thyroid carcinoma, we are going to be one step ahead of the tumor. If the tumor is involving only the thyroid, we are going to do the next step also. Central lymph node dissection is done along with total thyroidectomy. If it involves thyroid, also level 6 nodes are involved, we are going to do total thyroidectomy with central lymph node dissection with MRND. Similarly, if it is seen, if any other lymph node is also involved, the same procedure, this aggressive management is done. So we are going to be one step ahead of the tumor. If it is present only in the thyroid, we are going to do total thyroidectomy along with central lymph node dissection. If it is going to be present in the central node, level 6 nodes are involved, then we are going to do everything. Total thyroidectomy, remove the level 6 nodes, central lymph node dissection is done along with MRND. If it is also present in some level 2, 3, then we are going to do the same procedure. Total thyroidectomy, central neck node dissection and also modified radical neck dissection. And here there is no role for whole body iodine scan or radioactive ablation because they arise from parafollicular C cells. So they are not going to uptake the iodine, so there is no role. If there is any metastatic disease, like if it is metastatic to the liver, then we are going to give tyrosine kinase inhibitor like vanditinib and cabozantinib. Thank you.